It's my privilege to introduce Dr. Andrew Wagner. He's a colleague in our medical oncology department. Andy is truly a physician, a scientist, and a great teacher, and he's going to talk to us about non-GIST sarcomas, targeted therapy.
So thanks, James and Jonathan, for the invitation to speak, and thanks to all of you for listening, especially those of you who are here for the GIST part of it. I'm going to talk about other diseases. Probably 99% of sarcomas are comprised by many other types of tumors other than GIST. But some of the topics I'm going to talk about today are also quite relevant to GIST in particular. So just as an overview, there's probably on the order of 12 to 15,000, I have 11,000 cases up here, of sarcomas in the United States diagnosed each year. And it represents only about 1% of cancers in adults, and it's more common in kids as a percentage of all cancers, but still adults with sarcoma, there are more adults with sarcoma than kids with sarcoma. And as opposed to other cancers like lung cancer or breast cancer or colon cancer that arise in a given organ, sarcomas can arise anywhere in the body. And they resemble what we call connective tissue, the supportive materials in the body, and they have a common origin of a cell called a mesenchymal cell. And these can have the appearance of bone, cartilage, blood vessels, muscle cells, fat cells, or neural crest cells. And there are many different ways of subclassifying these sarcomas. And the most common language we use now are by the lineage of differentiation. So it's not necessarily where the tumor came from, but it's really what it represents. And I think maybe Dr. D'Adamo discussed this earlier as well. So one that looks like fat is often called a liposarcoma, a fat-containing sarcoma. And you can see all these different names listed here. And these are just a few of about 100 different names that we use to describe different types of sarcomas. Because they're rare tumors, we often lump them all together into one group and call them sarcomas and then test drugs against them. And this is set up to fail. Just like we wouldn't take a drug for colon cancer, breast cancer, and lung cancer and treat all of those together, we look at individual treatments for those different diseases. We should be doing the same thing in sarcoma, but again, because of the rarity, we tend to lump them together. And so our standard therapy for advanced sarcomas are conventional chemotherapy drugs, doxorubicin or adriamycin, with or without ifosfamide, and that's been our standard for probably 20 years. More recently, we've been adding gemcitabine with without docetaxel or Gemzar Taxotere, often as a second-line therapy. But until 2 weeks ago, there have been no new drugs approved for sarcoma in about 20 years. It's kind of an embarrassing situation for those of us who work in the field, and a desperate situation for those people who need new therapies. So last year at our big national cancer meeting called ASCO, 2 studies were reported looking at new drug therapies for patients with sarcoma. One was called Palette, and the other one was called Succeed. I'm going to go into them in more detail in just a second. Palette was a drug called pazopanib, which you heard about earlier for GIST, but it's pazopanib for metastatic sarcomas after prior chemotherapy had stopped working. And Succeed was this drug called redifferentiated, used as maintenance therapy. So after patients had completed prior chemotherapy and had success with that chemotherapy, meaning the disease was still controlled, they then could receive this drug. But before we go into those studies, I'm going to do some nuts and bolts about clinical trials and how the language that we use, and you often hear us talk about when we're telling you about these studies. So importantly, how do we report outcomes in clinical studies? And these are 3 different ways, and there are others, but these are 3 more common ways that we use to discuss whether or not a drug is successful. There's something called the response rate, and then these terms, progression-free survival and overall survival. So I'll go into these in a little bit more detail. So response rate represents the proportion of patients whose tumors shrank by some standardized amount. Our most typical measurement that we use is something called RECIST, which stands for Response Evaluation Criteria in Solid Tumors. This is a very artificial number, but it represents how much a tumor shrank, and if it meets that threshold of shrinkage, we call it a response. You can have what's called a partial response, which means it shrank by at least that much, or you can have a complete response, which means it's completely disappeared on scans or by examination. Usually, if the disease shrinks, if it responds, that's due to the drug. There are occasional diseases that can spontaneously regress. As far as sarcomas, the more common one that does that is desmoid tumors can spontaneously regress. But for most diseases, they're growing. The only way they're going to shrink is if the drug is effective. So in this case, if we're just testing a drug and there is a significant response rate, whatever that might be, X% of the patients had shrinkage of their disease, that's almost always due to the drug. So on the other hand, progression-free survival is another term we commonly use, and this represents the proportion of patients who have neither died, they're still alive, and whose tumors have not grown by some standard amount. So their disease has not progressed. So it's still often used as something like RECIST, but it says the disease hasn't grown by 20%. If it's grown by 15%, that's still stable disease, but that's freedom from progression. The disease has not progressed. That is still what we often see as a good endpoint for patients, is that the disease isn't growing or it's not significantly growing. So whether it's growing just a little bit, has stopped growing, or has shrunk, it all would count in this thing called progression-free survival. So one of the questions, though, is that if the tumor didn't grow, was that due to the drug, or was the tumor just growing very slowly on its own? And that's one of the struggles that we often have when we're testing drugs, and especially when we're testing drugs by themselves, is that if patients are just enrolled into a study, they're given a drug, and they only get that drug, we're assuming that the disease has stopped growing because of the drug, but in reality it could be the disease just grows slowly and we're not seeing significant changes just by the disease by itself. So how do we deal with that? We either compare it to historical controls, where we say, well, given our experience with this disease, we expect it to be growing in this period of time, or we randomize patients to two different treatments. It could be one of two drugs, or it could be a drug versus a placebo. And by randomly assigning patients to different treatments, we can then determine what the real effect of the drug is. Because if there's slow-growing tumors in some patients, they should be equally distributed among those two groups of patients. And so that's the only way we can really look at progression-free survival as an outcome from the studies. It's very dangerous when we look at, and we often do this, we report studies that have a single drug being used, and we report the progression-free survival, and we try to interpret that as a meaningful outcome. If it's dramatic, if a disease is not growing for 2 years, that's pretty clear. But when it's short, if it's only a few months, it's hard to tell if that, again, is the disease just being well-behaved or whether it's an effect of the drug. So the other term we use is overall survival, and this is the percentage of patients who are still alive. Of course, this is what is most meaningful to all patients and to their physicians as well. So again, we often will compare this to historical controls, so that at a certain time point, we would have expected that X% of patients would have died, but on this drug, Y% are still alive. Or again, we need to compare it to another treatment. Is one drug better than another treatment by the extent that patients are living longer if they're getting the drug? Generally, this is viewed to be the gold standard, again, both by patients and the providers, that we want patients to live longer. That's the whole purpose of these treatments. It makes the studies a little bit more complicated to do because you often need a lot more patients to enroll into a study to have a difference in how long people are living. So how do we report these values? The response rate we usually report as a percentage. Now, I acknowledge that we call it a response rate. Rate is per time. So it's not really a rate, but we call it a response rate. So what proportion of patients have shrinkage of their tumors? So we'll say the response rate was 45% as an example. So that means that 45% of patients had shrinkage of their tumors by some standardized amount. For progression-free survival and overall survival, they're often referred to as a median, the median PFS or the median overall survival, which is different than a mean or an average, and I'll explain that again in a second. Or we refer to as a PFS rate. So what percent of patients at 6 months had freedom of progression of their disease, or as a hazard ratio. And a hazard ratio is reflects a reduction in the risk of an event occurring. So just an example, we might say the median progression-free survival was 28 weeks, and again I'll explain the median in a second. Or we can say the PFS rate at 6 months was 37%. This means that 37% of patients did not have progression of their disease and were still alive at 6 months. If we say the hazard ratio was 0.5, that says that the risk of something happening, the risk of death, was reduced by 50% by this treatment. That's what the hazard ratio represents. So it would be 50% compared to something else, another treatment. So, and forgive me, I'm just going to give you a little bit more on statistics and then we'll be done with this. So the difference between a mean and a median, and this is really important because often these things are used interchangeably and they're really not. Mean means an average value, and we all remember from our 4th, 5th grade math what an average is. So if you take 1, 3, 5, 7, and 9, you add them up and divide by 5, that's the average value. That's the mean. So the mean of those 5 numbers is 5. And if you take 1, 3, 5, 10, and 101 and add those up and take the average, the mean is 24. 120 divided by 5. The mean is useful for repeated measurements of related values. So if you say, I want to check your weight, and I'm not sure that the scale is very accurate, I'm going to check it 5 times in the course of a week or 5 times in the course of a day, then the mean is a valuable value. It's an important value that you want to report. If you're looking at unrelated things, so 5 different people, you really care about the median, the middle number, the thing that represents the population the best. And it's not as skewed by outliers. So if you want to report what a typical height is of people in the room, if you have someone who's 7 feet 6 inches and someone who's 3 feet 2 inches, and the median is still going to be whatever in the middle of that. The average of that is going to be somewhere in the middle, but those people are not really contributing to the typical population. So a median should reflect the typical population. Where are people like kind of balanced about? So again, a median of 1, 3, 5, 7, 9 is 5, but a median of 1, 3, 5, 10, and 101 is also 5. Now look at the differences between the median and the mean. So the middle number here is still 5. So this is, again, what we want to use for unrelated measurements. So, for example, if we're looking at how well people do on a certain drug, what happens to one person has nothing to do with what happens to another person. And if someone is 100 years out from a therapy and someone is only 1 year out from a therapy, we don't want to average those together. Instead, we want to look at the more common distribution. What's the middle of that range that we usually see? And this comes up a lot too when we talk to patients about, patients want to know how long they're going to live with a certain diagnosis. And often the numbers that we have are medians, and that's not relevant to a given patient. So again, if you look at these examples, if we have people who may live from a diagnosis for 1 month and people live for 100 years, but the distribution looks like this, and I tell you the median is 5, it doesn't tell you if you're going to be in the half that does worse than that or the half that does better than that. But despite that, the median is often what we'll report in terms of clinical studies. It makes it very difficult to interpret for an individual patient, though. Sorry, I told you that was my last slide on stats. There's one more, p-values. I promise this will be the last one. So the other thing you'll often see is what we call a p-value. And a p-value represents the probability that whatever observation we're reporting was due to chance alone. And so when we design tests or studies, we want to know with some degree of certainty that the effects that we're seeing are real. And this all has to do with how many patients are enrolled, what are the effect size, all these different things. But in brief, the higher the p-value, the less likely the finding is real, and the more likely it occurred by chance alone. So by convention, we use a p-value usually of 0.05, which is 5%. So a p-value of less than 0.05 means that there was a less than 5% chance that this occurred by chance alone. So if we see something that's less than 0.05, we think that that's a real effect, and something that's more than 0.05, we think that that's just by randomness, we see this difference between two groups. You can see how arbitrary that is, because whether something is a 4% chance or a 6% chance doesn't seem like a big difference, but we usually set a pretty strict limit right at 5%. Okay, so going back to these studies now. So this Palette study was pazopanib, or Votrient, for metastatic sarcomas. And it blocks the activity of many key kinases, these proteins in cells that drive cancer cell proliferation. The drug had previously been approved for treatment of kidney cancer. And in the study, about 369 patients were enrolled. 2/3 of them received pazopanib, and 1/3 of them received a sugar pill. And what was reported was a significant improvement in progression-free survival. This is the median progression-free survival, that half the patients in one group in the placebo group had their disease progress by 7 weeks compared to 20 weeks in the treatment arm. So a 13-week difference. And there was a minor improvement in the median overall survival. That people receiving pazopanib, the median survival was about 12 months versus 10 months. And so this is what the curves look like. So this is the proportion of patients who are free of progression of the disease and are still alive. treated with pazopanib or with the sugar pill, the placebo. And when we refer to the median, we're looking at this 50% mark. So this is where half the patients have progressed. So half have not yet progressed. And so when we report the median progression-free survival, we're looking at a line drawn across here and looking at where these are different. So this is about 4.6 months on the pazopanib arm and about 1.5 months on the placebo arm. Now, that's a single time point. So that's the median progression-free survival. It's not a single time point. That's a single point, the median progression-free survival. Or we can look at what happens at 6 months, so PFS rate at 6 months. And you can see that about 30% of patients are still free progression on pazopanib versus 5% on the placebo. So there are different ways of reporting these data. And the p-value, this suggests that there's a less than 1/100th% chance that this occurred randomly. So that's a significant p-value. That means that this likely is due to the drug. So on the basis of these data, and as I mentioned, the survival difference was relatively small in how long people lived, but that's probably because a lot of patients went on to get additional therapies that may dilute out that effect. So on the basis of this drug was actually approved by the FDA 2 weeks ago. So the SUCCEED study, which was Redifferentiated, a type of drug called an mTOR inhibitor, and this is a drug which is similar to other drugs approved for kidney cancer and liver cancer, like rapamycin is a type of drug of this family. And these are patients who had control of their disease on standard chemotherapy, and then they were eligible to go on to either this drug or a placebo. Again, it was randomly distributed. We were not responsible for deciding who got which. A computer did. There were 700 patients, and half of them got redifferentiated and half of them got placebo. This study saw a much smaller benefit in how long a disease remained under control, with a median of about 18 weeks versus a median of about 15 weeks. And the hazard ratio, so that the risk of progression of the disease was lower on the redifferentiated. It was 0.72 with a significant p-value. And in contrast, look at these curves. They are not very different from each other. And again, if you look at this median, so at 50%, the median progression-free survival, they're very close to each other. There are other points where they're a little bit different, but in general, they're not very different. And actually, one of our professors here will tell us, you can tell if these curves are significant as to whether or not you can get 2 fingers between them. And that's kind of the standard that he uses for determining it. You can't get 2 fingers between these, but in these you can. So if you look at that, there's not much difference. But if you look at the area under the blue curve versus the area under the red curve, that's where you get the 72% hazard, the 0.72 hazard ratio they report here. So this one is unlikely to be approved by the FDA. We expect to hear by the end of this month. And the advisory committee that reports to the FDA voted very strongly against this drug being approved for treatment of maintenance therapy of sarcomas. So we'll get the final decision by the FDA by the beginning of June. So what did we learn from these studies? Well, one thing is that pooling together all these different types of sarcomas undoubtedly dilutes the treatment effect. So if we look at GIST, we have a disease, although we now are learning that it's actually multiple different diseases with different mutations and different behavior. But we basically have one disease where we can use one drug, primarily imatinib, and we can measure the effect. But if we took imatinib and tested against all these other diseases, we'd be at a loss. And actually, GIST used to be excluded from these types of studies because it doesn't respond to conventional chemotherapy. So we can look at these different diseases and say, well, some are likely to respond, some are not likely to respond. But we pull them all together, we're diluting out the effects. And from these studies, we actually have learned nothing about how to choose patients for these drugs, for pazopanib, for redifferentiated. So who is more likely to benefit? And that's a failure of us. We haven't been able to understand why it works in some people and not in others. But still, some patients do benefit by this approach. And the question is always, what's enough for the FDA approval? In the first case, the pazopanib case, it was. In the redifferentiated case, it's unlikely to be. An important part of that, too, is what are the side effects like? How toxic is the drug? If it's something that's well tolerated and has a small benefit, that's one thing. But if it's something that's very poorly tolerated or patients are dying from the treatment and it has a small benefit, we don't want to do that to our patients. I'm sure our patients don't want to do that either. So we need to be more selective in our testing of drugs in specific diseases. And for that side, we need to understand the targets, the biology, like KIT for GIST, and then find the drugs that match, so imatinib for GIST. Or we find drugs that work, and then we try to understand why. I'm just going to give you a couple examples of these things. And one is one of the more common types of sarcoma called liposarcoma. So this is, again, a malignant proliferation of these cells that differentiate along a pathway that looks like fat. And this represents about 20% of soft tissue sarcomas, so there's probably in the order of 2,000 cases per year. And there's different flavors of this. One type is what we call well-differentiated liposarcoma, which means it looks more like fat. It tends to be slow growing. It often can be cured by surgery if you can get a good rim of normal tissue around it, but it can come back usually in the same site as the original tumor. In contrast, it can also turn into a much more aggressive type of sarcoma called dedifferentiated, meaning it's lost that differentiation into fat. This often arises from well-differentiated liposarcoma. It can grow quickly, it can recur in the same spot, or it can spread elsewhere in the body. And it can respond to some chemotherapy, although the responses are usually not very long. And on a scan, this is what it often looks like. So this is someone's pelvis here. Someone's lying on their back, their feet sticking out of the screen, their head up that way. So this is their left side, and this is the right side. This is their belly, and this is their bottom, really. These are the pelvic bones here. And this is what fat looks like, but it's also what well-differentiated liposarcoma looks like. And these things here are dedifferentiated liposarcoma tumors, more solid appearing. Some of the other structures here are all normal. But this is a patient who's got both the well-differentiated and the dedifferentiated liposarcoma. Under the microscope, they look very different. This is what fat looks like for the most part. This is an abnormal appearing fat to a pathologist. But this is what well-differentiated liposarcoma looks like under the microscope. In contrast, the dedifferentiated liposarcoma, and these are all fat globules, and the dedifferentiated has lost that fat. And it looks like a lot of other kind of crazy-looking cancers can look like, this spindle cell proliferation of cells. So they look very different under the microscope. But despite their different appearance, they actually have some very common genetic abnormalities. And they both have activation, amplification, too many copies of certain genes that turn off these two really important proteins in cells that normally control cell growth. So in our normal cells, we have a protein called RB and a protein called P53. And these usually keep the cells in check. They keep them from growing too quickly. They keep them from growing out of control. And in liposarcoma, you have too much of these two other proteins, CDK4 and MDM2, due to problems just in the tumor cells where they make too much of these proteins. And CDK4 turns off RB and gets rid of it, and MDM2 turns off P53 and gets rid of it. And so these are just a few of the biochemistry slides I'll show you. I'm sorry, but so CDK4 can turn off RB. RB normally controls how cells proliferate. So you get rid of RB by turning it off with CDK4, and the cells can grow more quickly. And similarly, P53 normally controls how cells proliferate and how they survive. So normally P53 can kill cells if they get out of control. But what happens with MDM2 is it turns off P53, and then the cells don't die when they should be dying. So you have this problem in liposarcoma where you have too much growth and too little death, and that leads to a tumor. So this gives us the opportunity to test drugs that inhibit CDK4 or inhibit this MDM2 P53 interaction. And these are just emerging in the clinic right now. In the laboratory, we can show that they work. So this is a mouse that has had liposarcomas injected into its flank on either side. And this is a PET scan. This is what we call hot on a PET scan. This is what we look at on patients' PET scans too. This orange, yellow, white activity means a lot of metabolic activity. And when they're treated with this inhibitor of CDK4, it turns off, almost back to normal. Whereas in this mouse that's treated with a controlled drug, there is no improvement in the uptake there. And then if we look at what happens when we grow these in the mice, so that the controlled treated cells, the cells are treated just with almost like a placebo, the tumors get bigger and bigger and bigger and bigger. But the tumors that are treated with this CDK4 inhibitor, this new type of drug, the tumors stop growing. So this type of drug, this is a type of a CDK4 inhibitor, is being studied in people right now. I'll come back to that in a second. So the MDM2 inhibitor, similarly, we can test this in mice. And again, the mice tumors grow very quickly. And then if we treat the mice with this inhibitor of MDM2, which turns back on this P53 pathway, we actually completely wipe out the tumors. And even after we stop the drug, these mice have been cured of their tumors. Now 6 weeks, 8 weeks later, the tumors still have not regrown. And this just shows this is basically a PFS curve and overall survival curve for the mice. So these types of drugs are now just in those early stages that Dr. Butrinsky talked to you about, early stages of clinical trials. They're in phase 1 studies. Some of them are now in phase 2 studies. There's a variety of different MDM2 inhibitors that are out there. This one is the furthest along, and there are a couple others that are just entering the clinic right now. And for CDK4 inhibitors, there's, again, 3 or so of those that are in clinical study. This one is in phase 2 studies in liposarcoma, and the other ones are still looking at many different cancer types to see how well it works. So that was an example of how we understand the biology of the tumor, and we can use drugs to try to target that. And like I said, we're just getting to the point of seeing how well they work in patients, but hopefully they'll be effective in patients, but we need to do the studies to find out. Now, on the other side, here's an example of a drug that we used in patients, saw the response, and then try to understand why it's working. So this is one of those rare sarcomas called pecoma. And this is a gentleman who has, again, in his pelvis, these are hip bones here. This is tumor. Some of these other things are normal intestines, but this is a tumor here, and then this is a tumor here. The other structures are all normal. And he was treated with this rapamycin derivative called sirolimus, and his tumors actually, here after 9 months, they're much smaller. This thing here was this thing, and this little nubbin of a tumor there was this. They completely disappeared on therapy. And so when we started, and we had several other patients who also had this kind of benefit, and we started looking at their tumors, we found that these tumors have lost a protein called TSC2. And you don't need to know exactly what this does, but basically the tumor cells shown down here don't stain for it. This is a normal blood vessel within the tumor that does stain for it. But the tumor has lost it. And we found that in a few of these patients, their tumors have just deleted this whole area of the gene. And so just very briefly, don't look at all these different things, but there's this pathway, again, the mTOR pathway is here, and this protein complex, TSC1, TSC2, normally turns off this pathway. And what we found was that in these tumors, they lose this protein, so the mTOR pathway is hyperactivated. And so when we introduce a drug like rapamycin, we can turn off this hyperactivated protein and block the proliferation of these cells. So we'll skip through it. But that is an example of how we can see an effect in patients and then try to understand it in a laboratory about why that drug might be working. So there's a laundry list of different types of studies that we're currently conducting here at the Dana-Farber Harvard Cancer Center. Some of them involve regular chemotherapy, so doxorubicin with or without a new drug called polyphosphate or TH302 or some other combinations. Other things looking at patients who've had complete removal of their tumor and now they're being treated with a vaccine to try to prevent their tumor from recurring after it's recurred once before. There are other studies where as Dr. Petrinsky mentioned earlier, are in the earlier stages of drug development, these phase 1 studies of things like CDK4 inhibitors, MDM2 inhibitors, PI3 kinase or mTOR inhibitors, as we heard about earlier, that might be important in GIST or in other sarcomas. And something called hedgehog inhibitor, and this other combination of a diabetes drug with chemotherapy. And then we have other studies that are more sarcoma subtype specific. So these are looking for very standardized types of sarcomas and then testing drug combinations in those. Some of these, again, are typical chemotherapy drugs that we think are more active in these diseases. So that's why we've paired them up, although, again, we don't know why. Other are things that have some biology that suggests that these pathways might be important, like a hedgehog inhibitor in chondrosarcoma, this thing called denosumab in giant cell tumor, imatinib or nilotinib in chordoma, nilotinib in this other type of joint tumor, et cetera. So what we're really trying to do is to go both directions, though, to see we need to understand the biology to find new drugs, and we need to understand the clinical pattern of the tumors to understand the biology. And I want to reiterate this point that Dr. Petrinsky made earlier, that I think probably most of you are participating in these studies already, but if you're not, please consider them. The way we can do the study, the way Dr. Fletcher can do it, the way others of us can do studies of pathology materials is with your permission. And it doesn't involve anything on your part other than you saying, yes, you can use any leftover tissue samples for us to do research. And that gives us permission to work with our pathologists, to use old tumor samples, nothing new, just use old tumor samples to do these types of studies that we can identify these new targets. We can link it up with your clinical history and say, you got this drug and it works, so let's figure out why, to try to understand how to extrapolate those findings into other patients. So this is what we call our sarcoma tumor bank protocol. The profile is what the Institute is doing as a whole on any new patient's tumor that comes in, and then, of course, Project Flag for GIST samples. So just to conclude, these targeted agents may show benefit in small clinical groups. We need to understand why. but also identifying those pathways will help us target new therapies for other types of sarcomas. So thank you very much.
Thank you, Andy. Any questions for Dr. Wagner in the back? I'm going to try to run a microphone there.
You showed a slide with a mouse with a liposarcoma that had been set in its hindquarters or something like that. Are you trying to change treatment so it's less systemic? And are you, for instance, would you put a chemo solution into that liposarcoma so that, the borders of that liposarcoma limit the chemo as well as the... So are you playing with that at all?
We've not been doing that with these types of drugs. Often with sarcomas in general, they're in multiple places, and we can't, or they're in places where we can't put needles into them, so we need to treat the whole body. There is Dr. Rout, who spoke earlier with one of the thoracic surgeons, Dr. Yolanda Colson, have been working on a film that's impregnated with chemotherapy that they could lay down into a surgical bed after tumors removed. And in mouse models of this, you take a sarcoma, you stick it in the mouse, and then you cut it out but leave some intentionally behind and put this film down on it. It basically cured those mice. So that's a different approach, which is trying to reduce the likelihood of a tumor coming back in the site where it was removed. But we're not currently doing any studies where we individually treat different tumors with injected chemotherapy. It's really not feasible, unfortunately, for many of our patients.
When you do your studies of why cancer continues or not, are you studying ethnogenomic things and environmental reasons why this person was cured or not in your treatment studies?
We are not. Other people are doing these types of assays. Those studies need a lot of samples to filter out the normal variability that exists in the human population. And fortunately, in sarcomas, we don't have a lot of patients. But on the other hand, unfortunately, for those that have the disease, it makes it harder to study.
Thank you.
Sure.
About the cancer. And then you're talking about drugs. Who formulates the drugs?
Who creates them?
Well, first of all, you have to formulate them. What is going to work? What might work?
So it used to be a very, yes. Well, for the 99% of the time, it's pharmaceutical companies. They do it for two reasons. One reason is financial. This is why they exist. But another, the people there are motivated to help patients. That's why they do this as well.
You're the one that comes up with the pathways.
So that's a combination between an academic and an industry collaboration. So they have the resources to, on very large scales, to test new compounds. And they have the chemists who then can modify those compounds and test them and test them and test them and identify these compounds. Now, sometimes they have these compounds sitting around. And someone in academics will say, hey, let's test this against our model.
Or let's add another group and see if...
Yeah, exactly. And so even the story of Gleevec, for example, it wasn't, as you know, it's not being designed for GIST when it was being created. It was being designed for other things. Dr. Fletcher and his colleagues said, hey, this kid is also a target of Gleevec. Let's try it in our GIST models. And without that, so Novartis wasn't interested in it. It took persuasion of Jonathan and his colleagues to say, hey, let's do it. And then here are the results. It works. And then it still takes persuasion at that point to say, okay, now let's do the patient study. Because that's, but that worked. So it's a collaboration. And the problem is, so the companies will make libraries of these compounds. And then they have to think about, well, what do we want to work on? Because they don't have infinite resources either. So some of it, unfortunately, is focused on, well, what is the largest impact we can make, both in patients and financially? So let's go after lung cancer and breast cancer and colon cancer. And it's our job to convince them that, there's a reason. Look at Gleevec. It made billions of dollars for Novartis. Let's use these drugs in these rare tumors when there's true reason to look at those drugs. We can show you that the pathway is important in these tumors, so you've got to use your drug in this tumor. If it doesn't work here, it's not going to work somewhere else.
So Gleevec was made before you figured out
For GIST? Sure. It was, Jonathan can tell the story much better than I can, but it was called STI 571. It was a CB-Geigy compound, I think, right? Is that where it came from originally? You tell the story. But so it was being designed as an inhibitor of ABL, which is the gene that's involved in CML. And even then, that was thought to be crazy, that you couldn't have a drug like this because it competes with the major energy source for every cell. And if you did this, you were going to kill people. And it turns out that you can make these specificities among them. Or there's a drug, Nexivar, sorafenib. The name sorafenib, the RAF, is because it was being designed as a RAF inhibitor, initially designed to go after pancreatic cancer, which has a RAS mutation, which is just above RAF in the signaling pathway. So they say, okay, we got this great RAF inhibitor, let's use it for pancreatic cancer. As they were developing this drug, it came out that melanomas commonly have mutations in RAF. About 50 to 70% of them do. So now they said, oh, no, we designed this drug for melanoma. It's a RAF inhibitor, let's use it. Turns out it wasn't a very good RAF inhibitor. It didn't work very well in melanoma. A different drug now, vemurafenib, is approved for melanoma because it works pretty well. But so sorafenib was now being used against melanoma, but it didn't work very well. But it worked in some other diseases, like in kidney cancer. So now it's not even referred to as a RAF inhibitor. It's referred to as a multi-target kinase inhibitor instead. So, but it's been repurposed into a place where it works better. So the way it's originally created may not be the way it's ultimately used.
Synergistic and everything. Very interesting.
It's definitely a collaboration. And they can make the drugs, but we can show them the biology to go after. They do the biology too, but the patient care comes out of the academic hospitals too, right? So it's definitely a partnership. Last question I think we have to move on to.
Do we have any studies where people have been taking Gleevec for the last about 11 years? I mean, are there new technologies that have come up? Do they match the dose now with the individual needs? Or we continue with whatever dose we started in the beginning?
So for most patients on Gleevec, if it's working, we don't want to mess around with it. If there's toxicity, that's when we would modify the dose. Or if it's not working, that's when we modify the dose. But for most patients, we do use the same dose, and regardless of whether someone weighs 100 pounds or 300 pounds, they get the same dose.
So we continue as long as we can tolerate, right?
As long as it's working and it's not causing bad side effects, then yeah, stay on it. It's working. So it's like, we like to think of that as the way we would treat diabetes or something. We want it to be, if we can't cure it, which would be our preference, but if we, reality right now is we don't have a way to cure these diseases, then let's just control it with as few symptoms, as few side effects as possible.
Thank you.
Thank you.